Hi everybody, welcome to our last webinar for Oct5 ACP. We're very lucky today to have Sophie O'Keefe here to talk to us about working with families. So we're here in the complex neuro stream. So yeah, we're very excited about that. So I'm going to hand straight over to Sophie, who's going to take the slides and have a chat at the end. So feel free to ask any questions, put anything in the chat. We're very happy to answer any questions or make comments. That'd be great. Great to have a conversation. So enjoy. Thanks, Sophie.
Thanks, Cheryl, and hello, everyone. For those of you who don't know me, my name is Sophie O'Keefe, and I'm one of the lecturers here at Bundoora. So I have been teaching into ACP in the neuro stream. It's pretty exciting, I think, to get to talk to you guys today. I sort of had a pretty free range developing something that I thought would be important to talk about. So it took me a little while to think, you know, what do I want to share? And I think working with families is something that I have become a bit more passionate about over the last few years, both with some personal experience myself, which I'll touch on a little bit, but also as a clinician. And I think families are often our silent heroes. They're the ones in the background sometimes that cop a lot of the brunt of the changes that are happening. And I think they're also a key tool that we can use in our therapy. So, and often an unutilized tool as well. So today I'm going to be talking about with a focus of, I guess, a complex neurological impairment. And I've targeted it specifically to traumatic brain injury for those guys in the neuro stream. But I guess also the content transfers across lots of different areas when you're working with individuals and families who have had other sudden injuries, life-changing injuries, spinal cord injury and other orthopedic or chronic illnesses as well. So hopefully you get something out of this. I don't want it to, I don't want you guys to be just falling asleep with me talking. So please jump in with questions. I think it makes it a lot more interactive and interesting. But we're going to talk a bit about, firstly, the impact on the family who have somebody who has experienced a traumatic brain injury. We're going to talk a little bit about the common family responses, the stages of adjustment that families need to go through, triggers for family stress, and how we might be able to mitigate some of these, the importance and how we can really use the family as a tool in our therapy, and how important the family is in achieving successful rehab outcomes for clients, how to help families as well, and how to negotiate and how to help clients and negotiate their relationships and sexuality after severe brain injury, but also, with a touch on other injuries. So you can see here the statistics are fairly alarming. There's very high rates of marital breakdown more than 5 years post-traumatic brain injury. So it's approximately 78% of marriages break down, I guess, where the injured person has a severe brain injury, and approximately 42% where the injured person is classified as having, what you call a good outcome. So it varies quite a lot through the literature, and these statistics are relatively old, so bear that in mind. But certainly from my experience, there's very, very high strain on relationships. There's a high number of parents who have to give up work for their injured child who's now an adult. So it quite a significant strain on middle-aged people who are retiring and about to go into that next stage of life. And then there's also the impact on children. So children who have to adopt responsibilities that their peers, their friends at school aren't, children who are doing things around the house, children who aren't getting as much attention or as much support from their uninjured parent because they're having to support their injured parent. And then 25 to 30% of relatives, so close relatives, parents, spouses, caregivers, will experience anxiety or depression long term. So pretty alarming statistics. And I think it just really highlights why we need to really consider the family in the whole rehabilitation process as well, and really think about how do we help them through this journey, and if we can't help them, then what supports and what resources. So the family has to go through a series of and I guess they experience a series of stages after their loved one has a traumatic brain injury. So there's that initial shock response, and this is when they've had to rush to the hospital in the middle of the night, or they've had to call an ambulance, and that they've witnessed the accident. There's an immediate crisis, and the family sort of rushes to ICU, and it's a very life or death situation. And then they experience this, so their loved one pulls through, they survive, they're out of ICU, things are starting to look up. And so there's this sense of emotional relief, but there's also this sense of, denial of the long-term consequences, because it's often shadowed by physically. They can see their loved one is awake now, they're talking, that they've survived, so why won't they get back to normal? And that's coupled with, I guess, what we as health professionals generally label unrealistic expectations, but this expectation that they're going to return straight back to normal. And then once they start to realize that that's not actually the case, that there's going to be, a really long journey ahead, there tends to be this stage where they go through this bargaining process, they're mourning the loss, and we're going to talk a little bit more about these in the next few slides, but they're mourning the loss of who the identity of that loved one within their family unit, and they're starting to work through and think about what sort of adjustments that are going to be made. And this is a very confusing stage. There's a lot of mixed emotions. They flip between positive to having being quiet down in the dumps. And then the final stage, which really is, takes a really, really long time to get to this stage. And it's often not until their family members back at home and they're starting to integrate back into the community that they can start to accept what's happened, accept the identity of the changed identity, the changed role, and, the changed family structure, I suppose. So we see it, it's such a stressful process for families because all of a sudden there's this major disruption of relationships. There's a major disruption in the roles, in the responsibilities that people had, that they're not able to do, and the responsibilities that other people are having to take on. And this is sort of all coupled with that, now their loved one has survived and there's all of this relief, but everything, things are still sort of crumbling around from the outside, I suppose. So often you'll see, as I said before, parents of young adults who might need to return to being full-time carers. So they were starting to plan, the next stage of their life, retirement, maybe going on holidays, perhaps, downsizing and selling the family home. So there's this whole period of adjustment to changing what they thought was ahead of them. It's really, really tough on spouses. There's, the evidence just says that while it's difficult for parents, it's often more difficult for spouses, because they're not only often taking on the sole role of being a parent, as well as having to support their partner, their the injured person, but there's also that change in the emotional dynamics of the relationship. So they perhaps couldn't rely on them for advice, for assistance, for emotional support, where they previously would have. And again, children needing to take on different responsibilities. They often really mourn the loss of affection from their parents. And there's this real initial stage where the support, the outpouring of support from family, from extended family and friends and colleagues, is really quite overwhelming. But then gradually over time, people start getting back to their normal lives, and they start, and the families of someone who has a brain injury can become really quite isolated. So over time, you tend to see this awareness and grief starting to occur, and it usually, most of the time, in my experience, it starts to happen when the client is in inpatient rehabilitation. There's a little bit more reality, I guess, to the situation. So there's a lot of support, and there's a lot of, I don't want to use the attention, but, there's, the acute phase is very high. There's a lot of medical stuff going on, and if they're out of ICU, then they're getting ticks of approvals and tests that are coming back good. And going to rehab, is really quite a milestone. But then they get to rehab, and everyone else starts to go back to their normal lives, and the family really start to realize that they're not going to go back to the way their life was very quickly, because we're doing assessments of function and we're assessing cognition, and they start to see that, hang on a minute, they're not going, we wanted them back at normal now. Why aren't they back to normal? And it's really, really hard, I think, to grieve the loss of somebody, to grieve the loss of the identity that loved one had in your, held in your family unit while they're still there. There's lots of guilt. There's lots of, well, I should be thankful it's not me in that position. Why am I feeling bad? And then on top of that, the family is constantly confronted with their loss. So there's challenges every single day. Where are they going to go? How are they going to get home? They're not able to do that. They're not able to do this. So it's a really, really difficult time. So over time, the family needs, we really need to support the family to start to accept some of the, I guess, changes in personality or changes in behaviour that are being demonstrated by the individual, and start to integrate back into their family unit with new roles and new responsibilities. And then, the way that this happens in a family unit really is very dependent on the coping styles of the family, how flexible they are in their own family beliefs, and culture plays a really big part in this as well. And so if you think back to the cultural safety workshop that we did, understanding the family culture can really help you to start to help the family to rebuild their family network. Really encouraging the family to identify strengths that their loved one has, and to really place importance on that rather than importance on the things that have been lost. But I think it's really important as well that you give them permission to grieve, give them permission that they're allowed to grieve the person that they've lost, that this is a really difficult time for them. And I think as health professionals, we need to be really mindful that we're not we don't undermine the grief of the family because we place our sole attention on the client, which sometimes, can. And we ask a lot of our families sometimes, we ask them to be there for meetings. We ask them to reschedule work things, we're often asking a lot from the families. So we really need to advocate for them and make sure that they're getting the support that they need to grieve properly. So families are every single family that I've seen are just under this huge amount of stress, particularly after traumatic brain injury, because of the frontal lobe damage that often occurs in traumatic brain injury. So if you think about the mode of injury, it's often a car accident, or it's often a fall or assault, and quite often the damage is localized to that front area of your brain, which is where our emotional regulation is, which is where our ability to plan, problem solve, our executive functions are. So those changes really influence the way that individuals interact. So the way that they speak and interact with their family will change, and that causes quite a lot of stress, particularly if they're becoming irritable or if they're becoming violent and aggressive. Cognitive difficulties. So I think sometimes, I think it's much easier for families to understand and grasp physical problems. You can see it, it's much easier to understand, whereas cognition is much more difficult to understand. And I don't know about anyone else, but sometimes I have to stop myself with my grandmother, who is very slow and repeats herself all the time, and I'm there, sort of really getting, you've told me this already, and I have to really, stop myself and say, no, this is her memory and she can't help it. And it's much, much harder for families to understand some of the cognitive deficits, depending on the level of support they have. So families adjust much, much easier if they have practical support from extended family, if they've got help with the children, when their workplace is supportive, and also if they've got that social support as well. So they've got someone that they can debrief to. So as health professionals, we need to be making sure that we're advocating for the families to be seeking that sort of support. Quite often family members will have to give up work or take on new roles, which they will find very stressful, on top of already dealing with having a loved one who is now not the same as they were before. So managing the finances, where their husband and wife would have previously managed that, and then also pre-existing problems in the family as well really start to bubble to the surface with this added stress on top of it. A big one is communication with health professionals, and we need to be really mindful that we're communicating regularly with families. We're updating them, we're telling them what we're doing, because it just helps reassure the families that they know what's happening. And some families won't have a lot of knowledge about the medical system and what happens when somebody is in hospital. So the more information that we can provide about what to expect, then the better the family is able to deal with these situations as they arise. And a good example of that, and if you're in the neuro stream or if you've read the neuro case study, you'll read in the James scenario that his mum in acute hospital is quite upset that he's not receiving as much therapy as what the other patients are. And this is a good example of the family hasn't been set up with expectations, because James is actually in post-traumatic amnesia at the moment. And one of the ways that we manage post-traumatic amnesia is that we reduce the amount of stimulus that he's getting. So we want to make sure that we're preventing any further health complications and risks and those sorts of things. But we actually don't want him to be doing any intensive therapy while his brain is recovering and the swelling in his brain is going down. And so it's actually in his best interests. And if this was communicated in advance with the family and they were given some jobs that they were able to do, then his mum would be much more comfortable with the process, rather than getting all worked up and getting quite upset about what's happening and her son's not getting as much therapy as someone else, which is quite a common complaint of a family who's in rehab. And then the next, I think, one of the next things that's a main cause of stress to families is accommodation, having suitable housing. Where is my loved one? Where's my son or daughter, or where is my husband and wife going to go after they leave hospital? Am I going to be able to help them? Do we have the right house set up? So starting to talk to families really early on about some of these things helps relieve their stress in some of those areas. It's not all bad. So I think it's also really important to remember that we can learn from families. So some families actually cope surprisingly well, and they become stronger and more resilient because of these circumstances. There have been some studies. So when I was doing some research for this webinar, I found some studies that said that actually the family functioning, your long-term family functioning reported by relatives, was on average not significantly different to that of normative samples. I think we need to be mindful with that result because they were actually reported by the relatives. And I know from my personal experience, so my mum had a stroke about 5 years ago when I was actually working in neuro, and so I've had the perspective of being a family member and also being a clinician. And certainly after my experience of being a family member, my experience of the way that I worked with families as a clinician changed really, really significantly. But I know certainly from, my family's perspective and my dad's perspective is he certainly wouldn't be probably telling people that his family's not functioning very well. So we just sort of, I don't know, how honest those responses would have been. Not all changes in personality after brain injury are negative. So there have been some reports of people becoming more even-tempered or have a more positive outlook on life after having survived the trauma. So, people talk about, I have one client that I see privately who's had a stroke, and he keeps saying to me, it's actually probably, it's probably a good thing this has happened, because I really, I've had a chance to reinvent myself, and I can now see my potential, and I have all of this potential, and now I know that I want to start an online business, and I want to start this, and I want to start that. And I walk past people in the shopping centre every day, and I look at them and I think, you don't know how much potential you've had. You don't know until something like this happens what you can actually achieve in life. So it's important to keep all of that in mind, because we don't want to set a really negative picture for our clients and our families, but we do really need to be aware that it is such a tough time for them, and we need to respect them, and we need to respect their knowledge, and we need to help them as much as we can. The family is as much as our client as what the client is. I have to keep changing my little photo around because it gets in the way of the text. So the family is so important in enabling the client to achieve successful rehab outcomes. The family spends a lot more time with the client than what we do. The client will model the family more. So if we can teach the family our cognitive strategies, if we can support the family to problem solve, to model really good coping strategies, then the brain injury survivor or the client is much more likely to have more successful outcomes and to adopt these strategies in their own life. So it's really, really important that we're helping the client model those good behaviors, as well as being able to use them for their own well-being. And as it says there, there's a really strong association between an unhealthy function or an unhealthy family functioning and the rehabilitation outcome. So we really want to help families work together as a team. And the family needs to always be part of the rehab process. So we talk a lot in neuro about providing high intensity therapy and high repetitions of things, and patients doing lots and lots of hours of practice. And our key resource to achieving that really is by educating the family. They're the ones most invested. If you want to get anyone on board, if you want to teach anyone how to do something, the families, you think about the people who are most invested in the recovery of your client, and it's the family. So the more that you can get them on board, the better rehab outcomes you're going to have for your client. So when we look at families who really adapt to their situation, adapt to the new identity of the loved one in their family unit, they're supported by one another. So they have a really good, support system. They have structures in place that help them work as a team. And I think it's really important when I'm working with families. I find I'm spending a lot of time talking to families about how they can actually work together. And sometimes it sounds like it's really simple stuff and it's, common sense. But when people are in the thick of this cloud, they'll say, when they're in the thick of what's going on here, they can't make rhyme or reason, and emotions fly high, and there's a lot of stress and anxiety. So provide them with really simple strategies, timetables, getting them to set up a roster so that people can come in at certain times to do therapy programs. Work with them to openly express their feelings and emotions. Families that are more flexible to, identities and expectations of roles. So expectations about who should be the breadwinner, who should be looking after the children, expectations about who should be doing what. Families who are able to be more flexible around those generally cope with this situation much better. Families who can openly discuss changes in family members, they cope much better as well. And again, demonstrating to the family the strengths that their loved one has. This is what they're doing. This is, this is some of their identity that still remains. Highlighting some of that to the family is really, really important. Encourage families to remain involved in their outside activities. It's a really, really long journey that these families have to go on, and they have to gradually get back to the stuff that they were doing. All of that stops when they rush into ICU, but their loved one might be in rehab for 6 months, and then, it's a really long journey after that. So they need to get back to their cardio tennis or their yoga or their, whatever it is that gives them some leisure and enjoyment. They need to get back to that. Can't get to my next slide. Oh, here we go. So we've already started talking a bit about how to help our families. And I think you've probably already gathered that my ethos is that families deserve not just to be involved, but I really think they need to direct. They need to help direct the process. They need to be supported and assisted through the phases, all the phases of rehabilitation, of the hospital stay, from ICU to acute care to rehab and then beyond. And we need to give them an idea of what to expect at the next stage. We need to set them up with some expectations so they have an idea, so they can feel, so they can plan, so they can spend their time supporting their loved one rather than becoming surprised at every little road bump along the way. So we need to ensure, and I think it's important at this time to acknowledge that we're, as occupational therapists, we're not the sole profession responsible to support families. It's, the responsibility of everyone in the team. I think for us, it's really important to consider those practical things. Where can we, keep occupation at the forefront, I suppose? Where can we involve the family in some of the really practical, routine-based things so that they feel like they're helping, so they have their own responsibilities and tasks. And once the family feels like they're able to make a difference and they feel like they're helping and they feel like they're involved, then they're much, I suppose, not calmer, but families who aren't given that opportunity, they're more likely to complain. They're more likely to, constantly need to contact you and call you every day because they're highly anxious. It's really important when you think to make sure that your psychologist or your social worker is able to provide them some counselling. So I know in the brain injury unit that I worked in, most of the time when our patients first went into rehabilitation, they had fairly poor, after traumatic brain injury, they had fairly poor self-awareness, or they might have been still in post-traumatic amnesia. So at that stage, they weren't ready to talk to a psychologist. They weren't ready to talk about, adjusting to their illness, and they weren't ready to discuss their emotions because they were still, far too acutely confused. The psychologists and the social workers spend pretty much all of their time working with the family. They meet with the girlfriend, or they meet with the parents separately where they need to. They might meet with them together. The psychologist will touch base with them and do sessions. Investigate where practically you can support the families. So quite often we would have patients from interstate if they'd had a car accident and they'd been helicoptered into Melbourne, for example. So these families are spending, thousands of dollars on accommodation in hotels close by to the hospital every week. And there's processes through TAC, or there might be processes through the hospital where we can apply for funding assistance, and all of these little things help to make just help to reduce the stress of the family, help them to be able to focus on what readjusting and reorganizing roles. So I wanted to kind of just quickly touch on how we can involve the family through every stage of the hospital. And so right from ICU, we need to make sure that they've got information about diagnosis, information about what, about head injury, about what's happened. We need to make sure the information is all in a format that they can understand, and we need to make sure they've got emotional support. We need to involve them in some tasks perhaps it's as simple as teaching them, how to reposition their arms and in bed so that they're not going to get pressure care, how to help them wash their face and wash their hands. All little things like that really helps the family to start to adjust to what's happened. The more the family can be involved in the whole process, the more the family is able to get to that adjustment and acceptance phase. And that's really important for when we're planning, particularly from rehab. It's really important for when we're planning for discharge, because if the family isn't accepting, then the family's not ready to assist that individual back into integrating into the community differently to the way that they would have previously. In rehab, it's really important that there's one person in the team that can really be a key contact for that family. So orientate them to the new environment. A family is just, after 3 weeks in acute care, they've worked it out. They know which nurses to get information from. They know who the occupational therapist is and what they do. They know where to park. They know where to get their good coffee from. It's their routine. For us, it's very normal for patients to come to rehab. For the family, it's a huge adjustment. All of a sudden, they're in this big new land and they've got to learn how it all works again. So make sure that there's somebody there that can orientate them. Make sure they're given support and information about what to expect in rehab. Orientate them to all of the different things that they might need. And then I think by the time they get to rehab, the family's really ready to, they're going to want to start to discuss their emotions around the accident. So particularly with traumatic brain injury, families are often there when it happens. They might have been in the car. They might have, they might have witnessed something. They're ready to start talking about and debriefing about some of the trauma associated with that experience. And there's often a lot of guilt. I should have done this. I should have done that. I could have stopped it. I should have prevented it. Again, discuss the therapy plan in detail with your family from day one. Tell them what's happening. Prevent a PTA occurrence where they're not getting any therapy, but when they're not getting any therapy and they shouldn't be getting any therapy, but the family sees it as they're not getting a fair deal. So keep them on board the whole way. Things that help families is written information. So they're so overwhelmed by this stage that they're probably not taking in any information. So written information is good to deliver it verbally and deliver it written as well. You really want to be having frequent family meetings with the team. We had a rule, and you'll probably hear this out on placement, is that nothing should be a surprise. Discharge, no sort of information that's happening on rehab should come as a huge surprise to families. They should be told every step of the way what's happening. The best way to do that is to have family meetings so that everybody is on the one page, and then follow up with the individuals after to make sure that they've understood the information, they know what's happening. Discharge is one of those situations that just creates a lot of anxiety for families. That often ask really early on in admission, what's going to happen? When will they go home? What's the end result? What will they be like? And this is something that's really difficult to predict really on, but it's also really stressful for us to answer. I know I've spoken to a lot of my colleagues and some of the junior OTs that I used to work with, and those questions used to come up a lot. I just want you to tell me what they're going to be like. And it's really stressful for us to answer those, because we feel like we might be held, well, you said they would do this, and you said, they're not going home until they can do this. So try, don't make early predictions, but really try and reassure families by saying, by discussing with them, this is what we're doing at the moment. This is a likely time frame. Set up expectations that it's a really, really long way. It's a really long journey for recovery, but they'll be supported every step of the way. Be prepared to repeat the same information many, many, many times, and don't get frustrated. And even if you provide written information, don't be surprised if they ask you the same information again. it's just really hard for families to take in this information, particularly if they're in the denial phase, because they don't want to hear it. They're not ready to hear the answers to those questions yet. But when they are ready, then they will take it on. So if they keep asking you, then you just need to keep providing the same information. You need to start preparing the family to take over the supportive role. At the end of the day, we can only be involved in the process for a short time. What we might feel like is a long time, 6 months in rehab really is a short time in the rest of the person's life. So the more prepared the family can be in supporting them, the closer, the closer that they get to the individual, knowing how maybe it's how to position their affected arm properly, all of those handling skills that for us, we learn and develop them over time and they're second nature, but for families, they're really, really confronting. And just be really prepared to problem solve. I think we have a lot of guidelines and a lot of standards that are really, really important to follow. But give families the opportunity to problem solve and, if they don't follow all of the rules all the time, but they understand the consequences, then that's so okay. And we need to support families with feeling like that's okay, rather than condemning them for not following the guidelines, I suppose. How do we assist families in denial? It's really not unusual that families are going to refuse to acknowledge the significance or the longevity of their loved ones' injuries. So when this happens, they're usually going to have a view that, their family member, their loved one, their husband and wife's going to recover back to what they call normal, that they're going to go back to work in a few weeks' time, and their expectations that I guess we can think are quite unrealistic. And I've seen in the past a lot of rehabilitation staff who talk fairly negatively about, that family's just got unrealistic expectations. But confronting the families when they're in this stage with, hard facts and laying it out on the table just isn't helpful at all. And I sat in a family meeting with my mum and my dad and my sister, and we had a lovely care coordinator who had kindly calculated the fees of 24-hour nursing, I think it was, for a whole year, and presented those sums in front of my parents on a table, and then presented the residential care application paperwork, and basically said in this meeting, this is how much, this is how many million it's going to cost to fund private nursing, which is, an unrealistic amount that probably only Bill Gates or someone like that can afford, or here's the residential care paper, and then basically push the residential care paper in front of my dad to sign. All that resulted in was dad pushing the piece of paper back at them, standing up and waltzing out of the room and not wanting to have a bar of it, which really left our family unit no closer to any kind of resolution about how we were going to pull it all together. What we actually needed was someone to sit down and talk about what some of the options are, and allow us to go away and do some research ourselves, allow us to come around to the fact that no, it's not going to be normal at home. How do we compromise somewhere in the middle? So it's really important that you allow the family that time as well. You can't expect them to make decisions on the spot, and you can't, our job is to provide them with our job is to provide them with informed knowledge, but we have to be really careful with that informed knowledge, because I know even myself, we can influence decisions in the way that we provide information. So by by putting that sheet of paper that's in front of my dad with millions of dollars that basically says you can't do this option, and then putting the residential care paperwork, that wasn't providing a choice at all. That was trying to convince him to go the option that the hospital wanted him to go, and that's that's not the right way to do it. We need to be giving our families, we need to be supporting our families and allowing them to make the best decisions. I'm hurrying up, Cheryl, so we can have some questions. Families need to talk to people who've been through the same experience. So there's that saying, you don't know what it's like until you've walked in their shoes. They need to connect with people who've had the same experience. So seek out support groups for them. Introduce them to other families on the ward. Whatever it takes, allow them the opportunity to spend time with other people who have the same experiences as them. Because unless you've been through that experience, you don't understand what it's like. So you can provide support, but they need to talk to somebody who's been through the same experience. I'm gonna whip through this negotiating relationships part, because I really do want to open it up to questions. But negotiating relationships is really, really tricky. And what I'll say about this is, particularly in traumatic brain injury, we have a lot of young people, and we have a lot of young males. And we don't always, when we're talking about relationships, we're not just talking about long-term relationships and marriages. So we need to be really open-minded about how we're supporting people to negotiate new styles of relationships, but also supporting people to leave relationships if that's the best, if that's the best decision for both people. None of these decisions are made overnight, but we need to make sure that we're supporting both the partner and the client at the same time, because these are really hard decisions. And if you think about it yourself, these are decisions that you don't want to be put in the position to make yourself. So provide opportunities for couples to spend time together. Provide uninjured partners opportunities to debrief, to let out their emotions and feelings without feeling guilty, and encourage couples to really talk openly. This isn't always possible depending on the amount of cognitive impairment. So again, it's not our sole responsibility, but as a member of the team, we really, and I think OTs are notoriously really good at building strong rapport. So people do open up to us and they do tell us these things. So be really careful with your initial reactions and just be really open-minded, and support both people in the situation. Again, sexuality following TBI. It's really important that we acknowledge that this is actually a factor that needs to be considered. More often than not, we're too scared to talk about it. A lot of OTs are females, a lot of TBI survivors are males, so it makes it even more uncomfortable. If you don't feel comfortable with how to discuss it, then seek the support from someone who might have a little bit more experience with that, because it is a tricky topic to negotiate. But if there's one thing that I want you guys to do, is just to be aware that it's something that actually does need to be addressed. So you take home messages, and I'm sorry if it was a bit rushed at the end, but traumatic brain injury really has a significant impact on family members and partners. It's really important that we consider the well-being of the whole family, because this has a huge impact on overall rehab outcomes. Families are going to be the ones who provide the most support going forward. So they need to be part of the rehab program at every step of the way. They need to know what's involved moving forward, and they need to start, they need to be utilized. They want jobs. We need to utilize them to make sure that our patients getting the maximum amount of therapy as they can. We need to make sure that they're well informed, they're well educated, they know who to speak to, they've got they've got access to counselling, they've got assistance with financial and legal issues. And we need to acknowledge that the adjustment period is going to be really long for them. And I think this is something that when you're a new grad, you're really good at doing, because when you see patients who have had such a significant life change, you can see the enormity of the situation. What you need to do is keep that in mind the more experience you get, because the more patients that you see, the more that you normalize this experience. So for you, okay, well, it's really traumatic now, but you will come to accept it. Don't push that on families. Allow them to accept what's happening in their own time. All that you will do is damage the relationship between yourself and the family. And you really need to keep that relationship really strong, because the family is the best resource that you have to achieving successful discharge. And as I've harped on about, achieving their rehab goals. Importantly as well, the family is going to need support across the TBI survivor's whole life. So not just that small time when they're in rehab or, before they go home or when they get home. It's really tough for a really long time. So we need to make sure that they've got access to support. We're thinking about what practical support that we can be giving them. And if there's something that they ask for, then it's usually something that they need, because, not all most families aren't very good at asking for things. Some families are good at it, but, if they're going through a really tough time and they ask for help with something, try and help them out, because it just takes the burden off them. All right. We have about 5 minutes left. Is there any questions?
I'm back.
Awesome.
Do you want to shut down your slides?
Sure. Stop sharing. Is that what I'm doing? Yes.
Yeah, that's right. Great.
Do you have any questions for me, Cheryl?
I do. I was thinking about, you talked a bit about the new graduate, and I think that's really interesting that as a new graduate you actually have more capacity to think about the impact, and that we do normalise that over time. But I was also thinking about that tricky balance between wanting to give people information but not knowing what the outcome is and maintaining hope. So it's that tricky thing, isn't it? You want to keep talking to them and telling them, but knowing what you can say in terms of possible outcomes, because you don't know what that outcome is. You can't know.
Yeah.
Even with lots of experience, you can't know, because it depends on so many factors.
Yeah.
So what advice do you give people with that, I suppose?
My first piece of advice is that it is really, really tricky. So if you don't know how to do it at the start, then don't beat yourself up about it. Last year, I ran some focus groups as part of a research study with clinicians in a brain injury unit, and experienced clinicians were bringing up, we're saying, I don't know what to say. I'm too scared to say they will go back to work or they will do this one day, because I feel like if they don't, then I'm held accountable for that. I did a bit of reading on it, and what the qualitative literature says is that at those early stages, families mostly want hope, and they're not going to hold us accountable to what we say. So while we want them to accept what's happened, they also need us to believe in their loved one. They need some belief to get them through, and so often we need to just give them that belief that one day, I can't tell you exactly when that will be. This is what we're working on now, but one day, we will, he or she, may go back to work. I can't, something like that. It's tricky. It's such a tricky balance.
And right. I think I really liked how you reminded us about being strength-based. We've talked about that with working with children, but we also talk a lot about, assessing and finding out what we need to find out what are difficult so we can plan interventions. But remembering that the strengths and resources are so much about reminding what people have and what they can use. And that, I imagine, helps the family engage with working with those strengths as well.
Yeah, definitely.
Now, I've got a little question.
Yeah.
So, Inika, can you read that, Sophie, or not?
I can. How do you engage with, for those who can't see it? So the question is, how do you engage with families who are not getting along with other family members or significant others in the TBI survivor's life? Which sounds very similar to what's happening in the case study. Again, it's really, really tricky, but it's quite common because roles, particularly with young people, because roles are changing. So, roles change overnight. There's no warning. And so 1 minute, if we think about the James scenario, 1 minute Grace is the girlfriend who, comes home and debriefs every day and sees James every day, and they might only see the parents once a week. So all of a sudden now, the mother, so Donna's, quite overpowering, and she's gone into protective mother, helicopter mother zone, because her little boy is, been in an accident, and it's her, it's every mother's worst nightmare. So there's a lot of emotion flying around, and people kind of don't really know where they fit anymore. And I think it's really about, it's just about talking with them. I think I spend a lot of time building rapport and listening and trying to give them a perspective from the other person. So talking with the girlfriend and explaining why the mother, she doesn't mean to do it, but this is what, this is why she's, and then talking to the mother to say, this is, Grace is feeling, she's feeling a bit left out, but there's just a lot of sessions in trying to, it's not really educating, but, trying to negotiate new family roles, because they're changing all the time. But yeah, we need to support the family with negotiating who fits where. The thing that I find works the best is give people tasks. Mothers need tasks. They need something to do. They need to feel like they're doing something. So if she doesn't have something she's responsible for, that's her job, then she's going to, she's going to be very overpowering. And so I'd be getting her to do some of the upper limb therapy exercises and, get her involved and giving her responsibilities, because when people have things that they're responsible for and they feel like they've got their little section that they're looking after, then often that calms the waters a little bit between everyone.
And it makes sense, doesn't it? Because that's that, you can't wait till the day they leave to then take on that role, because where would you feel
No.
comfortable that you're not breaking something, that feeling
Yeah.
of, well, I don't know if I'm doing the wrong thing because they were the experts and I'm not an expert. So it's helping them feel like they're an expert in the story, really, isn't it? And they have an important role to play, whatever that role is with their family member.
Yeah, I think I spent too long as a if I think back, I spent too long as a clinician wanting to be the expert, and now my focus is really I'm not the expert. I'm just the one there helping you guys problem solve. I'm just the negotiator, or I'm just the middleman, because there's the moment that you remove the family from being that expert in that person's life, then it really it causes a lot of conflict between you and the team and the family, and it's much harder to all work together. And it also creates conflict within the family, because people are fighting for for their roles and where they fit in the picture.
And I imagine, just thinking about that problem-solving role. We have a role in terms of, you're talking about expertise, a role in terms of interpreting evidence, best evidence. So in some ways, thinking about our clients and the stories and understanding their strengths and what they can do is thinking about how to translate some evidence to whether it's going to work with our client as well, isn't it? Because you're the one who has to look at what's recommended, what's possibly the best, but is that going to work here, considering all the factors? So that's, there's lots of areas that you're helping to make sense of, really, isn't it, in terms of your planning, intervention planning, because there's so many elements to it.
Yeah, there is.
I had another question, and I know it's 4 minutes past 5, but I'm going to ask anyway. So feel free, anybody else. I thought it was really interesting talking about, relationships and sexuality. And obviously, like you said, a lot of the clients that you see are young and in relationships, maybe think about having a family, think about whatever. It's that tricky thing, isn't it? Whether it's that or whether it's another area where you don't feel comfortable knowing what to do or knowing how to answer. What do you suggest if you have developed a good relationship and they give you a little something that you think, that was the thing. They were giving me a hint that they wanted for me to explore that, but I don't want to talk about sex with anybody. So what do you suggest? What do you suggest to people coming out and developing their confidence? Because we know it's really important. And for everybody to think about it, and for somebody to help them work out, well, things have changed. What do we do? How do we navigate this?
I think the most important thing is to acknowledge it. If someone says something to you quite overtly, don't. I think sometimes because we don't know how to address it, we can go, that's not really so try not to do that, because the moment that we do that, then the client gets the impression that, obviously that's not, I can't talk about that, or that's not suitable, that's not suitable for me to talk about, I'll never be able to do that again. So I think your initial reaction is important, and just try and stay calm. And now I usually say, look, I'm not an expert in this, I'll see what, tell me more, tell me about how you're feeling. And then, I can find someone who can give you more information, or who can talk to you about it a little bit more. If they're sort of just giving you a little and quite often I work really closely with the neuropsychologists and the psychologists in the unit, who tend to be, and we've had a couple of male psychologists as well. And so I'll go and have a chat to them and say, look, I think this is something that might be that we might need to talk about? Is it something that you could talk to them with, or go away and maybe find out some more information and then go back? If they've just kind of given you a little feeling that's something that they might want to talk about, that's probably how I would do it. But I think just remaining really calm, and just honest. Like, I don't know, not my area of expertise, but I know, and normalize it a bit. But I know that a lot of people have said, it's very common to feel that way, or it's very common to be experiencing that. And I know that we can, there is somebody who can talk about it with you.
I think it is that acknowledgement, isn't it? Or that, is that something you want to talk about? Or, and then saying, even if you're listening and then acknowledging and saying, well, gosh, yes, and let's find someone who's, you're comfortable with talking about
or
that.
Acknowledging, that is, I can understand that, that you're feeling like that. Let's, see if there's someone we can talk to, like you said.
And like you said, it's, we have that problem-solving role, don't we? Because we do able to think about, well, there's physical issues, potentially behavioural, cognitive, emotional, whatever else. So we can think through all the possible elements to think, well, yeah, there is somebody who could help you talk about it or manage it or whatever it is that they're starting to talk about. So
yeah. Yeah, I think the most important thing is to acknowledge it and to, kind of just sit in that space with them for a moment, even though you might not know how to address it.
Good advice. So those lovely participants are being very quiet, even though I think you're very friendly and would very happily answer any questions, but that's okay. And it is 5:10. So I think we might wrap it up, unless there's anything else you wanted to say, Sophie.
No, I think that's happy. I'm happy to take questions via email if anyone has any more questions.
Yeah, and also
I'm going to specifically answer your intervention plan questions.
No, because we know you have the capacity to think through that yourselves. But I will pop a little forum in LMS, so if things do come up, we can, we're happy to help you to help answer those as well. So feel free, please.
Excellent.
All right. Well, thank you, Sophie, for today. It's been I think it's great I think you're right in terms it's really important information to reflect on in any area of practice, and thinking about our role as, new graduate OTs or OTs, thinking about how to consider all those factors is really important. So thank you.
Thank you, Cheryl, and I hope everyone has a lovely afternoon.
Great. All right. Well, thanks, everybody. We're going to head off. See you later. Bye, everyone.
Bye.
Thanks, Sophie.